well. So much so, we're 3 to 6 times higher in the emergency department than the urgent care. This is a study from det.org. Common diagnoses are there. It's a bit of an eye chart, but allergies, acute bronchitis, earache, sore throat, the things that, are pretty common to get at least once a year with you and your family, maybe your children or your parents. All of these things can be treated in an urgent care, and urgent cares are open almost as long as an emergency room, and they're literally a third to almost half the price. And so very important that we educate our patient consumers as we move forward as an industry to help drive costs down. We've seen this. TransUnion Healthcare is also managing and monitoring hospital visit data, and emergency room volumes, both in our clients and across the country, are at a deficit. And I feel that ED visits were probably overutilized before COVID, and then when COVID happened, you really couldn't go. You had to have a virtual visit or maybe another setting of care. There was this fear of contracting COVID as well, and many hospitals are starting to understand, like, what is our strategy, and do we want those ED patients back or not? It's a feeder for our inpatient, our surgical, our cardiology, our radiology units, or can we get them in a primary care or urgent care setting and have them come there? And I think organizations that are structuring their intake in a way that allows for patients to enter their system in a frictionless way and avoid the ED are going to find that for the long term, they're actually going to have more revenues and lower costs and better outcomes by driving care to the more appropriate setting. Kaufman Hall, one of my favorite reports, comes out every month. It's the flash report. This is February's. March should get published here probably this week, if not already. They have really cool data, gang. The link is there at the bottom. Talks about what's happening by market in terms of your revenue, your EBITDA, your outpatient ED, inpatient volumes, your supply costs, your labor costs. Anyway, they've tracked hospital margins per a Kaufman Hall proprietary index, and they said that it's negative 0.1 right now with the CARES funding from the Provider Relief Fund, and negative 0.6. So everybody's in the red as of February, according to Kaufman Hall. I've talked to a lot of hospitals. Usually I'm talking to 2 or 3 a week, and health systems. Most of them are on their path to recovery. Most have not made it out of the woods yet, they've said. They're planning on doing that in Q3, Q4 of this year, and hope to kind of shake the water off the tail after swimming around in the COVID pandemic lake and start running again and hunting and getting those volumes back as quick as they can. The U.S. healthcare system really has become a sick care system, I call it. It's an episodic system with lots of waste, lots of returns, lots of overutilization, I would refer to. JAMA agrees with me to the tune of about $800 billion with a B dollars, and they're saying about a quarter of that, or $200 billion, could actually be saved. These categories here are a little hard to read, I understand, but basically administrative complexity or just overhead is that kind of salmon purse category there. Fraud and abuse is that next one, very small portion. A lot of people think it's fraud and abuse is the big one. Pricing, which I know is a very sensitive subject right now with transparency, is that large orange block. And then you've got overtreatment or overutilization, as I mentioned, to the tune of about $100 billion. Care coordination, handing off to post-acute or handing off to the acute care from the tertiary care has been a huge problem, and that's about $75 billion or $78 billion per JAMA. And then failure of care delivery, actually providing care that made the patient worse or not better when they came in. And JAMA did a study, and this was great. They did it in partnership with Humana. They actually looked at each of these categories and said, hey, from a range of about $191 to $282 billion, we feel there's opportunity in the healthcare system to help track some of this waste. I'm a lean guy, silver certified. Many of the folks on the phone I know are Six Sigma, lean certified. You know, if you go and look at any area within healthcare and just spend a week or two on it, you're going to find hundreds of thousands of dollars in opportunity in making things more efficient. It's just a matter of stopping, looking, reacting, and trying to drive these costs down so that we can all make it a better place. Social determinants is a huge element of that. My first book talked about 10% of the population representing 90% of costs. They are because of these factors over on the left in those kind of dark cylinders there. You know, where and how you live determines more about what type of health and wellness you have. These social determinant elements of ACE, race, gender, education, how much money you make, where you live, how you eat, whether you own a car or not, whether you rent or own a home, whether you live by yourself or not, all go into these insecurities of social risk there in that rainbow in the middle. And that drives outcomes. Total cost of care, how much care is being used, how well you perform on quality, morbidity, mortality, and ultimately how the community is doing in a health and well-being standpoint. Those that have worked in hospitals like myself understand there's a revolving door and episodic care of those frequent flyers, those chronic diseasers, the diabetics, the obese, the congestive heart failures that just keep coming back, the drug seekers, the suicide attempts. All of those patients drive a lot of cost. Healthcare works. It's just, it's being used in a way that is driving a lot of outcomes in a direction that we don't want. There's a lot of disparate and I would argue quantifiable needs that need to be addressed upstream. And admitting to a hospital ultimately is pretty much a failure, in my opinion, for a lot of the challenges that are presented. The only exceptions I could do are maybe elective procedures such as maybe pregnancies or new hips or orthopedics or things like that, to where you're actually seeking the healthcare system out to have something happen. But in most cases, short-term acute care centers are there because something went horribly wrong upstream from like a trauma or something else. And so it's very, very important to look at these social determinants and understand how data and analytics can drive better outcomes and understand them. And I'm seeing a huge movement in this now as we move forward. To make matters a little harder for hospitals, you're seeing disruption from folks like Walmart Health. They operate about 6 hospitals now, they call them, out on the East Coast. I encourage you to look them up. They're actually pretty interesting if you're a Walmart shopper. They look very similar, and you can get your vision, dental, and other services there. Minute Clinics, part of the Walgreens chain, have these clinics. They've been ramped up pretty significantly in the vaccine distribution. I'm sorry, CVS's Minute Clinic. Walgreens clinics as well have been ramped up and are seeing most diagnoses. And Target and most grocery store chains, you're starting to see like these clinics. And gang, they usually have a price list posted there that shows, hey, this is what your cash price is going to be today if you want to pay it. And it's listed, and it doesn't change, and it's transparent, and it's bundled with the professional fees as well. And it has, I'd say, 75% of the diagnoses that most people seek out healthcare today for. Go look them up. Go look these guys up and see. And my point for hospitals today, as this era of uncertainty is happening and this era of payment and volume is happening, is, are you going to be on those lists? Are you going to be a choice? Are you maybe partnering with these types of clinics and looking at them? Because they're growing exponentially. This is a little bit of a dated report. It's about 5 years old, but I guarantee you there are probably 3,500 to 4,000 retail outlets now providing medical care that you used to do. And my point with this is that it's frictionless. It's easy. The payments are there. There's no disruptions. People aren't getting bumped off the schedule. They can call. There's not hold times. They can buy tires while they get their flu shot. I'm not kidding. It's the new wave. You're not going to be able to do everything, but a lot of your ambulatory volume is going to fundamentally shift to these retail clinics that have figured out how to do it better, faster, and cheaper. And that's the generation that's coming into the healthcare market right now. And they want better, cheaper, faster. They don't want to sit in a waiting room in a hospital or have to wait for a bill to come. They want to get it done right then and there. So as a hospital, you've got to have good bait. You've got to look very carefully at your revenue cycle and understand, where is there friction? Where are patients onboarding to me? Why am I making it hard for them to pay or understand what they have to pay? Why am I sending them envelopes in the mail? Why can't they pay in advance? Why can't my payers pay me more quickly? What types of things am I doing as an organization in terms of bad data going across the wire that's causing them to happen? How can I collaborate with my payers to where they want to send their volumes to me and want to pay my claims? You've got to present yourself as a data-driven organization that's leveraging everything you have in your power to position yourself as the best hospital in your community that drives a frictionless patient experience for payment and clinical outcomes, so that payers and patients want to work with you. I have not seen the payer and provider relationship more adversarial than I've seen it now. There is just a general disdain for payers. Well, guess what, gang? A world without payers, I used to work for one, is a much, much different area. and you've got to figure out how to work with them. Work on those contracts. I've got all kinds of tools and things. If you need to call me, let me know on innovative ways to bridge that gap. I know they play hardball. Their job is to manage care. Their job is to help these healthcare costs of $3.6 trillion get better. And they should be paying claims in a more, I would argue, transparent fashion. The point is, right now, there's just like everyone's throwing their hands up going, forget it, and they're walking away from each other. And we know, even in our personal relationships with our wives and our children, that doesn't work. We've got to come to the table with data and figure out how we can best manage it. So why is it so hard? Why are we having such a hard time with healthcare? As I mentioned yesterday in the CFO panel, healthcare payments rival most people's rent and mortgage right now. You are spending as much on your healthcare as you do on your home. $21,000. That is up $6,000 from 20 years ago. Not that 15,000 was that great of a number anyway. But my point is, you don't pay as much attention as consumers, and I would argue our patients don't pay as much as consumers as we do with our rent or our mortgage. Think of how long it took us to find an apartment when we were first looking for one, or the house that we live in today, and how many mortgage places we looked at, and what rate we were going to get, and whether it was going to be a flex or an arm, and all of those things, and how we look at it and understand it and refinance. We don't do that in healthcare as much, yet the spend is the same. Employers have the largest burden of healthcare costs today. They spend about 60% of employer contributions, of all contributions. 50% of all people in America get their health insurance through employers, and employers are representing the lion's share of all payments when it comes to commercial or private insurance. In the first book, I talk about how employers really didn't want to get into this mess. World War II caused an inflation scare that caused a wage freeze. And that wage freeze incentivized, or tricked, if you want to use that word, employers into offering, as part of the salary and benefits package, and a health benefits plan to employees. We are, gang, one of the few, if not only, countries in the world that tie healthcare insurance to your employment. It's a great thing if you have a job. It's a horrible thing if you don't. And if you don't have good insurance, we'll talk about that in a minute, it really starts to impact it. And so employers, I would argue, are either trying to make this game a lot easier. They're directly contracting with providers. Some of those retail clinics I talked about, they're steering that care. Walmart, Boeing, Cigna, Microsoft are all huge companies that are saying, you want a hip done? You got to go get it done at Mayo. That's the only place we do hips. We'll fly you and your wife or your partner out. You guys can hang out there for a week in a 5-star hotel, and it's still cheaper and better outcomes than if they went to their local hospital. That's the type of thing that's going to start happening from the employer market. And payers actually love it because it's helping them drive costs down too. The benefit plans are getting structured in a way to incentivize steerage to places that have lower costs and better outcomes. No copay, no deductible to go here, versus if you go there, it's a full $2,000 deductible. Those types of health plans are becoming very prolific. High deductible health plans, I think, unfortunately, are going to bubble back up a little bit more than they have in the past. COVID caused some unemployment shattering to happen within the healthcare market. About 1 in 5 or 21% of folks per a Commonwealth study right now are what's called underinsured. What that means is they've purchased insurance, such as a health benefit plan or an ACA type plan or a high deductible or consumer directed health plan. That plan has $1,000, $2,000, $3,000 deductible. Most people only have liquidity in their bank account of about $300 to $400. So they're already underwater when they go into a hospital to pay their bills. And they don't know it. They purchased insurance. I may not need that. But when they go in, that bill comes. And all of you that are working in revenue cycle have seen your patient balance after insurance, your self-pay AR, inflate dramatically over the last couple of years. And COVID didn't make that any better. And a lot of it's due to the cost shifting that's occurring from the employer to the employee in the deductibles. Now, I think they've plateaued out. We've done some analyses at TransUnion. We've got some reports, happy to share those with you, where I don't think you can only squeeze so much air into the balloon of deductibles. People, once they get to like $6,000, $7,000, $8,000, $9,000, $10,000, it's just a big amount that no one will ever pay, and it ends up being bad debt. And I think we're at that point as an industry, but I do think the proportion of folks that are in high deductible plans is going to increase into 2022 just because of some of the unemployment fallout that we've had. I present a lot, gang, and I hope to God one day, I pray every day that I don't have to show this slide, but medical care is still the #1 cause of bankruptcy. Unexpected bills that come in, that large stack on the left, 67% of people that go into bankruptcy are because of some sort of medical issue and those bills. Mortgage is #2. It's resulting and manifesting itself in uncompensated care. I'm a data nerd. I go out there and I wait for this report. It's like my late Christmas present. It comes out from the American Hospital Association in January. Pay attention to the right side of this column. For the third time in 3 years, uncompensated care has increased from $38.4 billion to $41.6 billion. And you're also seeing a corresponding increase in the uninsured rate. That little dip you see there to the left of all that data was because of ACA or Obamacare that came in, the Medicaid expansion, those types of things. Gang, that was 6 years ago, right? 7 years ago when you really started seeing some of that happen. We're out of that, and I would argue that was a patch on a hole to help people get coverage, but it didn't address cost, it didn't address utilization, it didn't address affordability. And so here we are seeing an inflation in both the amounts that hospitals are having to write off, $300 million more in 2019, and the number of people that can even afford to get on insurance in the first place, that's going up, not down. So this is a bad path. We'll see what this report looks like in January, but it wouldn't impress. I wouldn't be too surprised if we approach the $42 billion mark. There are some studies out there that have said, well, maybe because of less utilization, because of COVID, that bad debt number will go down. But we really only had a blip of about, I'd say, 60 to 90 days of that. We still had a whole year, 3/4 of a year worth of pretty, I would argue, normal volumes for the most part from a recovery standpoint. We're still at a deficit now, but I still think the bad debt will manifest next year. So now that I've thoroughly depressed you, let's talk about how you can get paid as a hospital or provider organization. The payer mix is diluting. I've heard this from many CFOs. We heard this on the panel yesterday as well. Charlie mentioned out there at Valley View that his Medicaid and Medicare are going up, and he's pretty much on a government plan now. I think 56% is what he said was his payer mix. While at the same time, he's seeing his private insurance go down. I've done a projection here into 2025 based off some AHA data. This is their chart book report off of all hospitals that have reported in that are members. And basically, you're going to see a significant shrink in commercial private insurance. It was 33% about 4 years ago. It's probably running in the low 30s now. Maybe high 20s. It's going to go down to 22%, gang, in about 3 years. And the reason for that is you've got Medicaid, Medicare, you've got uninsured, all kind of squeezing that balloon, and private insurance is becoming something that only employers are offering, and it's on a self-pay ASO market as well after ERISA. So very, very important to understand how these plans are being structured and what does your forecast look like going forward. And I've got more data on this if you need to see it in terms of why I think this is going to happen, but COVID made this worse. It amplified this. I think the unemployed rate didn't get as bad as we thought, but it did happen. And employers and employees got dramatically impacted by the pandemic. And because of that, you're going to have some ripple effect, or the pebble in the pond, I call it, with uninsured, Medicaid, and basically high deductible health plans, which is going to all inflate your self-pay AR and your bad debt risk going forward. With all of this disparate revenue and bad news I've given you, you've also got disparate data. People are coming in with encounters. You may have merged hospitals. You may have acquired a physician clinic, and those all have different pieces of data where they may be spelled Jonathan Wiik with a C or with an H or different names. I may have switched insurance or jobs. I may have came in one place and had an MRI, but the other place doesn't know. I may not have paid my bills and the other doesn't know. You try as a revenue cycle to put that through your revenue cycle pipe to capture as much earned revenue as you can, and you hope you get it. But we're all here today to learn why we don't, right? We have a crack, and it starts to leak, and your dollars start to diminish. And that's because these gumballs or data encounters over here on the left, if you will, aren't verified. I heard yesterday many times A lot of the stuff needs to be moved upstream. You need to figure out where in your data sets are there validity issues and verification issues that aren't occurring, that you can fix them from both patient and payer demographics in terms of rules and likelihood of payment. You gotta do it. I don't know how many hospitals I've talked to that have ran eligibility transactions, but they're not acting upon them fully. And I don't know how many hospitals I've talked to that are submitting claims and they're managing their denials, but they're not preventing them fully. And there are ways to do that leveraging data. Let's talk about everybody's favorite term, the D word. It's not a four-letter word. Initial denial rates. This comes from our friends over at HBI, Health Business Insights. I know many of you are members as well. Initial denial rates across the country are running anywhere between 10 and 15%. Here in the West, we're considered Colorado, lower right corner. Hospital outpatient initial denial rates, if you want to bounce that off, is about 11%. Inpatients 14, EDs running just south of 16%. Reasons for denials surround medically necessary. I've talked to lots and lots of hospitals, and inpatient authorizations for partial or full days are the #1 cause right now, and you're arguing with the payer about whether or not this patient meets criteria per interqual or Milliman. Dupe claims is the second most common. More information or clinicals needed prior auth. There it is, about 1 in 10 claims requiring that. And then a patient not eligible or enrolled. This is just an analysis they did. I have this report if you need it. Very, very good. They broke it down by types of hospitals as well, but in the interest of time, I'm just going to keep cooking. Underpayments. Are you getting paid what you think you are? I love this MGMA study. HFMA put it together and quoted some stats from MGMA. Just running the numbers with you. MGMA says 7 to 11% of claims have an underpayment on them. They're not paid right. That's a lot. About 1 in 10, if you will. Let's just walk through these numbers. Typical encounters at 250-bed hospitals, maybe about 1 million encounters, right? That's $70,000 to $110,000 or 110,000 claims. Let's just pretend each one's $1,000. That might be high, but hey, we're in a presentation. It's kind of fun to embellish a little, right? That translates to $70 million to $110 million of risk annually. Let's assume you're doing right. You're a CFO, you're VP of revenue cycle. Yeah, I think 80 to 90% of my stuff's running great. If you're doing 95%, you're still burning, throwing in the fire, $5 to $6 to $10 million a year. And you know as well as I do, the payer will not call you. They're not going to pick up the phone and go, hey, Mr. Wiik, we didn't pay you right. We're going to submit some claim or some payments back to you in your next monthly check run because we just weren't paying you the right amount. That burden of proof is on you as a provider to hold them accountable to your contracts. Every year you renegotiate them and say, hey, I'm going to get this 2, 3, 4% increase, and you forecast it, and then you go back and look at it, and you're running like 2.1, 1.8, 1.9. Like, where'd my money go? Well, some of it went to the patient because it shifted there. We've talked about that. I would argue another large portion of it is because the payer didn't process and pay your claim right. And you've got to have line item detail looking at why that occurred and really be armed with that. I worked at a payer. We had a whole floor of analysts that just looked at this stuff to make sure we weren't overpaying anybody. And you could bet the payers invest a lot in that. They don't ever want to overpay a claim. So back to these gumballs we talked about, or this disparate data. If you've got the right data and analytics package and you're taking all this disparate data from multiple sources, possibly multiple instances of your EMR, if you're combining professional and hospital billing, or you've got multiple encounters on highly complex patients with complex bills, you've got to run them through a data and analytics package that matches the data the right way, takes some of those social determinants elements that I talked about as well, believe it or not, runs through patient behaviors and risks so that as patients are encountering their care at the hospital, the doctor, the clinic, and being discharged, you know what kind of outcome they're going to have, what kind of costs they're going to pay, how that payer is going to handle that claim or not, and what types of behaviors you need to change as an organization to be better and to hold everyone accountable, including patient and payer. I put it in these 3 stacks. These are kind of the mantra at TransUnion, but I love these. Engage patient early, ensure earned revenue gets paid, and optimize your payment strategies. You guys are all smart folks. You can read. I'm not going to read those to you, but you first got to make sure patients know what their coverage is and what their payments are. And if you try to do that through an envelope in the mail, it's not going to happen. Second stack we just talked about. You've got to make sure you've got line of sight as to where your payments are coming from and where they're not, and to ring the bell when they're not, and to be very, very specific as to why they're not, and to demand it, right? And then your payment strategies. What's your AR look like? What's that aging? Is it dusty? Is it getting larger or smaller? Everyone's AR right now, not last year, but right now, should be shrinking. If it's growing, please call me. Your accounts receivable should be coming down. You should not have a lot of dollars out there that you cannot get at. There are lots of tools and techniques and things to make that a manageable revenue stream for you. And that counts for both patient and payer as you move forward. I put this checklist together. This is great. CFOs or VPs of revenue cycle or directors of patient access or directors of billing. If you've been multitasking this morning, put down your donut and your coffee or your Facebook and take a look. This is like the top 10 Letterman things you got to do in your revenue cycle. I'm not going to walk through all of them in the interest of time. You know what these things are, but you'll notice words like hardwired and frictionless and prevention and scrubbing. You got to just do these things. Don't check that box unless it's hardwired. I'll give you the example of eligibility. You may be running RTE eligibility through Epic, for example. That might even drive to a queue where people are looking at those responses. Does that patient account switch to self-pay after some period of time? It should. Otherwise, you're doing it for free. You can just wave at the train as it goes by. A large majority of denials that happen at a hospital are because they did not act appropriately on the eligibility response and reconcile that with the patient and the payer prior to services being done. Not after. You guys know how hard it is after. That's just one example. Every one of these little boxes should go through there. Print off this slide. Walk around and make sure. And if you have questions on any one of these 10 bullet points, call me. I got workflows, tools, all that stuff from my times in speaking on each one of these to talk about what you can do specifically to make sure that your revenue cycle is performing at its best. Let's talk about the future a little bit. This is one of my favorite chapters in the book. I was writing the book before the presidential election, and so there's a lot of kind of political predictions in there. I was right for some of them. I was off a little bit on others. We'll see where we end up with things like Medicare for All and public option and things like that. I don't know how much those are going to stall or move, and we'll see what happens here in the midterms. But America, of all the issues on there, look at that. The economy, immigration, education, foreign policy, they ranked healthcare number one. 1 in 3, over 1 in 3, America said, the top issue facing us right now is we've got to figure out our broken healthcare system and fix it. Medicaid expansion is one way we have been fixing it. You can see here just as we go through the states, how they've been added. I've found it impressive that the states in the South have slowly been adding. Even Missouri and Oklahoma are proceeding this year in their Medicaid expansion. We extended the PHE and the FMAP percentage as a country just last week. That goes into September now. It was going to expire here in April. We have, I think, states looking at their waivers. President Biden also sent a letter to the states that have at work 1133 or other types of waivers that are preventing folks from really actively participating in Medicaid to look at those things very carefully. And I think you're seeing states like even Florida, Michigan, Georgia, Alabama, Mississippi very closely evaluating their status in Medicaid expansion. And I wouldn't be surprised if we see another 1 or 2 states in the next 18 to 36 months transition. Now, I've talked to folks in Texas. I don't think it'll ever happen. And I can talk to you in the networking session afterwards about why that is. I think they'll be the last ones to hold out. But you're noticing Medicaid expansion, and those of you that have studied this, you know when an organization or a health system transitions to Medicaid, outcomes are better, access is better, costs are lower, and it's just a win-win for the state and the hospitals. Funding's an issue. States are in a budget windfall because of COVID-19, so we'll have to figure out how to best balance that. But in the end-to-end, long-term, the states that expanded Medicaid have had better financial longevity than those that have not. And I have those studies if you need to see them. This slide's got a lot of information on it. Just in the interest of time, I'm not going to walk through all of these elements, but I'll highlight a few. We put this together for a legislative update for our team. We've got folks in D.C. too that are tracking this very, very closely. I'll go through the left column just to kind of level set you with those. Obviously, the number one priority for the legislation right now with President Biden and his cabinet is the COVID response. They're going to keep doing that, get that vaccine out, get us back. He's got that July 4th goal. All hands on deck. Let's roll. They extended the PHE. Payers are positive and negative with that because you've seen them have a pretty good 2020 and a good 2021 first quarter. They've released the results because they didn't have a lot of claims to pay during COVID because a lot of the elective procedures were shut down. They're actually trying to spend their money. They're creating foundations. They're investing in tools to help with their analytics and those types of things. They may or may not have a good result depending on where we're at. I think when the economy comes up, everybody benefits, but the payers are in a weird place, right? Premium tax credits, you guys know about those. Those are going to benefit. ACA is going to benefit everybody. Again, the payers, depending on how they're structured and what markets they're in with the exchange plans, may have a disparate outcome there. Price transparency, talked about that a little bit yesterday at the CFO panel. Really, the only benefit is the patient. Providers have to go through the burden of doing it and may have some dilution of their contracted rates depending on how compliant they are with the mandate. Payers really don't feel that they actually have to comply with this mandate in 2022. They feel they may lose some negotiating power in terms of rates that they could keep, lower rates, that they feel that they may be held back and have to provide a higher reimbursement rate going forward with some of this transparency. And pharma and life science won't be able to actually set their prices in a lot of these things, and they feel that's not going to be beneficial. Surprise billings, got a mixed bag across the top. Telehealth, it peaked out about 70-80% during the pandemic. It's about 20% for most organizations right now, maybe 15%, and I think it'll probably stay there. We'll see what happens with CMS and the commercial payers. We've got to reach patient or payment parity with that, and I think the providers are going to have some concessions too, because to be frank, a telehealth visit is not going to warrant the same reimbursement as an in-person visit. We're going to have to come up with some sort of agreement as an industry there between provider and payer as we move forward. I'll let you read the rest of those, but public option I'll just point out because that's on the state Colorado state ballot. I think we're going to see something of some sort. I don't think that one will pass in the way it's written. I also don't think on the federal level we're going to see a huge amount of traction with this in the next 12 to 18 months, simply because we got a lot of other stuff on our plate, and this is kind of a nuclear type thing. And President Biden may try to squeeze something in before the midterms, but we'll watch that very closely. For the future consumers, this is a New England Journal of Medicine survey, said that roughly 82%, there in that top bar, feel that hospitals and health systems are either extremely or very responsible for controlling costs. So that's where the patients and the government and most everyone expect this to happen. Very interesting survey from the New England Journal of Medicine in terms of where they think. So we own, hospitals and health systems, the solution to managing costs, according to the survey that was done. And I think a key to that's going to be the right level of care. Virtual care right now, per this study, and this comes from Help Hopefully, I love this, says that 1 in 5 types of things could be replaced with some sort of virtual solution. I think we got a good test drive and a good catalyst of that during the COVID-19 pandemic. And so I think the future is going to have a lot of things delivered virtually that weren't maybe before. And I've heard hospitals and health systems actually like, you know what, we may not have it replace lots of things, but things we weren't getting paid on anyway, follow-up visits, post-op that were bundled, behavioral health visits, we're going to spin up virtual because that's less overhead for us just to have a call that way and to talk to the patient that way. So very interesting as you look into the future, that virtual health is going to be there, and it's going to, like I said, hinge upon that payment parity as we go forward. Smart medicine, I'll spend a few minutes on this. This is one of my favorite chapters of the book, Beam Me Up, Scotty. That thing on the very left is actually the Star Trek tricorder, if you can believe it or not. If those of you that are old like me remember Star Trek and Scotty and Bones and the tricorder that they'd wave over people that made that noise. Dexter made one. The name they may not have wanted given that show that's on Netflix, but nonetheless, it does about 100 diagnoses. It's got a little 12-pin or 20-pin port there, and it can measure pulse ox, heart rate, blood pressure, temperature. I don't have all the list in front of me, but as those things start to come and you think about, well, how's the patient going to get it? Who's paying for it? Who's the insurance company going to pay for it? Where does that live? Those types of things. And you'll see that start to happen going forward, I think, as we look into the future. Where does revenue cycle fit as technologies and these come forward? The one in the middle is a company called Proteus, and that's not a nicotine patch. That's actually a patch that a person that's on medications pretty frequently, like a diabetic or a congestive heart failure patient or maybe a cancer patient would wear. And then those little pills there are electronically encoded. And so this is a medication adherence play. And this company, it's overseas, the FDA hasn't approved it here yet, has seen increases in medical adherence and medication adherence rates 3, 4, 5-fold. Most of the time, patients fall off the rails in their care plan is because of dosage and confusion surrounding their medication. This tells you when the pill was taken, if the person that took it was the one that was supposed to take it, how many they took. It also alerts the doctor and family if they didn't take it. So just think about that as grandma and grandpa or maybe on their pill or someone who isn't having different challenges in their life. This alerts the caregivers and family members to make sure that they stay on that medication to continue through that plan. Imagine the savings in pharmaceutical and downstream costs when patients do fall off the rails and become train wrecks in your EDs with a solution like that. Payers would love to fund something like that, I think, as well. That's an example of a technology that would. On the right, and I just saw a news blog yesterday, Amazon's already doing this, gang. I don't know if it's going to be by drone or not, but you can get your drugs on Amazon. They partnered with PillPack about 3-4 years ago. I think they're going to start sending things like these other two things, the Proteus product and the Dexter product and other things in the mail. Medical efficacy, patient responsibility and stewardship with that. There's some patient safety and danger issues. But from a reimbursement standpoint, these are all patients that would have probably gotten in the car and gone to an urgent care, primary care, one of those retail clinics I talked about. They're going to get their care in their home. How's that going to be funded? How are you going to be involved as a healthcare organization in that? Where are those patients going to shop? Where are they going to get their care? How's it going to come to them? As you look at all of these things, patients are really interested in their healthcare right now. I told you over 1 in 3 are. We did a survey. This is from a few years ago. We actually redid the survey, but I haven't updated the graphic. But I love these stats. Little less than half of patients freak out and go to the doctor when the economy is going bad because they think if the economy is going bad, they're going to lose their job, and they want to get in one last visit before their health insurance goes away. 75% of patients, it's actually now up to 80% of patients, and I remember when this number was 10, 20, 30%, look up healthcare costs before they go. Lower right corner, 65% of them want to pay you, but they need an estimate before time. If they don't have an estimate, they don't trust it and they don't want to go. But 65% of patients who get an estimate are willing to make a partial payment when they come to see you. All that said, they're not making super huge decisions on cost. They're still kind of going where they're told or where their wife or their neighbor told them to go, per this study from New England Journal of Medicine. We've got to change this paradigm. I'm not saying patients should defer or deter care because of cost, but it should be a factor. It's a factor with everything else. We don't go out and buy a Ferrari when we need a car. We don't go out and buy a $5.6 million house when we need a house. We don't sail to Fiji when we want to go on vacation. Some of us might, but we typically have some cost and financing decisions before that happens. Now, healthcare, I get it. It's something that happens to you. You don't go happen to it. Nonetheless, that cost question and that level of care question hasn't really manifested itself in healthcare as it had in other industries, and I think it's going to. So be prepared to make sure you've got those lists. I know transparency is hard, and I know that legislation was written in a weird way, but nonetheless, patients are looking, but their behaviors haven't changed. And I've seen some innovative hospitals start to go like a restaurant style, where they have like $1 for the primary care, $2 signs for the urgent care, $3 signs for the ED, and $4 signs for inpatient. And they've said, hey, when you seek care, look at this chart. Just like when you go to a restaurant or pick a hotel, you know whether you're going lobster or taco, right? And sometimes a lot of those things can happen at that gatekeeper setting, and patients just need to be educated there so they can make a decision on cost as well. Otherwise, it'll manifest as bad debt in your organization. Patients want to pay you this way. Can they? They probably can. Every other industry in the United States, you could pay this way. You could buy a car this way now. You could buy your groceries this way. You could buy a plane ticket this way. You could pay for your meal at a restaurant this way. Healthcare can get there. Now, can you pay the bill fully to the penny? No, there's variability in care. Healthcare is an art, not a science. I get it. But Apple Pay, waive it. Here's a credit card. When I was at my hospital, we collected a credit card on all self-pay patients that had a balance, I think, over $500. The reason why was because we didn't know what that bill was going to look like. And we didn't know what it was going to be, but we wanted to get a funding mechanism plat. And the way we worded it was we said, look, just like you check in for a hotel for incidentals, we're going to swipe a card. And then that way when you leave, we'll bill that card. We'll send you a letter and say, hey, you left us a card ending in 3456. We're going to bill $60 to it. Patient could opt out at that point, but at least we're having a conversation with them. And think about it. They pay partially with this. Maybe they pay fully if it's like an x-ray or a lab test that you know that that's it. It's episodic. Orthopedics, cardiology, surgery, open heart, that stuff's going to be more dynamic, but maybe they pay it each time they come in. And it's dynamic, and it talks to them, and it has a payment plan, those types of things. The technology exists today. You got to look at it, because if we don't, I really think if we don't transform it, we talked about this yesterday in the CFO panel, the government's going to do it for us, gang. And we all know what happens when the government starts to impact the private market. They've impacted the public market with CMS, with Medicare, Medicaid, TRICARE, CHAMPA, those types of things. You know, I would argue they're pretty transparent with those rules. They haven't done a bad job of managing those payers. The MACs are a little wacky depending on what region you're in. I think we're still in Meridian in Colorado. My point is, when the government starts messing with private insurance mixes, understanding like what you're supposed to do as a hospital in terms of a patient's accountability to their bill, or their accountability to their care plan, or their accountability to whether they're insured or not, those things start to become really dicey because now we've got more regulatory and administrative burdens as we move forward. That was all I had for you today. I know that was a lot, but I hope it was insightful for you. I challenge all of you to go out there. The last letter of the book, or the last paragraph of the book says, lead, follow, or get out of the way. Be bold. Go out there and make a difference in your revenue cycle. Get to that frictionless payment. Get to that data and analytic-based revenue cycle to where you're making decisions based off data, and that you're holding your payers accountable, and you're engaging your patients for a good financial experience. I've got about 6 minutes if you want to put a question in the chat. And then, as Jessica mentioned, once we hop out of here and go back to the exhibit hall floor, you guys can go up to the TransUnion booth over there and put some information in, or talk with me. And we'll get you a book so you can read more about what I yammered about today. But thank you so much for your time.
JW, thank you again. As always, amazing information. And what a great slide deck, huh? We will have those available on W8 or the HFMA website. Again, if you want Jonathan's book, just step over to the TransUnion banner and he will provide one of those for you. I have one myself. Thank you very much. And do we have any questions?
Are there any questions I can help answer?
A couple of minutes, please put them in the chat. And Jessica just put the link in the chat for the presentation. I'm pretty sure there's going to be a lot of people downloading that presentation.
Yeah. Hey, Jonathan,
yeah,
there was
sure.
a question. There was a question that was put in.
I have some stuff in the appendix as well, and you know, we talked through, you know, if you don't believe where this patient risk is going to happen, this slide here kind of talks about, you know, how patients owed about 10%, maybe 20 ago, and now they owe a third of the bill. And then you can see how that payment kind of stratifies into 3 different buckets. And that those orange and yellow ones are that uncompensated care I talked about, that $43.6 billion that's out there. The blue is the payment that you might get, but you're only going to get half. I heard the stat the other day, only half of what a provider organization bills out actually comes back. The other half goes into these other buckets of charity and bad debt. Really sad kind of state of affairs. I don't think many businesses could survive on that type of thing. So if there aren't questions, I'll be over at the booth and we can hop over there. But Jessica, do you see any? Or
I do. Can you hear me, Jonathan?
I can, yeah.
Okay, perfect. We did have one question that came in pretty early on in your presentation, and that was, can you please explain what you mean by administrative complexity costs?
Yeah, so that was from the JAMA study, and whoever that was, feel free to email me and I'll send it to you, the joint JAMA-Humana study. And I like it when, like, I'm sad that payers and hospitals aren't getting along right now. I think that's going to hurt our industry more than it's going to help how we get to the table. So I love seeing a study where the Journal of American Medicine and came together and said, hey, let's look at healthcare and understand where we're at. So the administrative complexity, when I read that report, talked about payer rules a lot. And it talked about how kind of the shell game that happens. Oh, this didn't require an off yesterday, but it does today. Oh, you've got to hop on one foot, sing Whistle and Dixie, and spin in a 360 before you submit this claim, or it's going to spin every time. All these weird rules about mutually exclusive edits, correct claim edits, those things. And then the payers also talked about, hey, your credentialing file's not up to date. Your provider directory is not up to date. We've told you that you have to submit clinicals when you submit us these types of cases, and it's a waste of our time. That's administrative complexity, yes, but if they've told you, you should do it. And so I think there's fault on both sides, and that's what it talked about. Like, if you can kind of get to some level of agreement, and I would use the T word here, transparency, between what are the rules to get paid and what's the penalties, compliance in making that happen. That's what that was talking about. And it was about $50 to $100 billion, if I remember right, in the industry, if we could get to some level playing field with the complexity of payment and claims. That was what the disconnect was, if that helps you.
Awesome. And it looks like maybe one last question here.
Sure.
Why do you believe providers don't make decisions based on data analytics? If not based on results, what are they basing their decisions and strategies on?
Yeah, so let me be clear. I think many providers are getting it right. I would say 99, 98% of providers out there are leveraging BI tools. They're running retrospective analyses on their things, but they're missing out on 1 to 2% of their revenue, their net patient revenue, because of underpayments that are not aware of, or disparate data inputs that they didn't validate and hardwire, like that checklist I showed you in the beginning. So I fundamentally believe, clinically and financially, providers are making decisions based off data. My point in this presentation was there's data out there that can get you to that other dollars of revenue that you're not capturing today from both patient and payer that you think you might be, but you're not. And that data and analytics strategy needs to be surgical. It needs to be laser focused on those things like patient payment probability, coverage discovery, understanding your denials package and your likelihood of getting paid or not, and the risk on your claims, those types of things, to where you're not leaking that revenue or actually growing as an industry and looking at it that way. And providing data and analytics in a holistic manner allows for that protected earned revenue to be back put in your coffers. I hope that helped clarify it.
Thank you. Again, thanks, JW. So we are here at the top of the hour. We're going to be jumping over to the exhibit hall.